So are we gonna have an exam for every single chapter that opens? Aside from chapter 2, I mean.
Chapter 1, chapter 3, chapter 4. And then you have a combo of 5 and 6. Those are your only exams minus your final. So 1, 3, 4, and then a combo of 5 and 6.
Why are we taking 2 week-long breaks? One in, well, of course, spring break, but then the other one.
Oh, the April one? Oh, I know, I'm looking forward to that.
I thought that was
What's
weird.
in April?
It's just like a midterm break or something, that's what they called it.
Yeah, that's what's on the calendar. I saw that and thought that was weird.
Interesting.
I know it's gonna cut into Thursday class twice.
I'm also not opening the extra credit that I mentioned, but don't panic yet. I'll make the announcement. Because the show open right now. There's a sign-in sheet going around. Please make sure to sign in. Hello, hello, hello.
Finish chapter one. I don't understand why there's so many check your understanding for chapter one.
Yeah, because it's the intro. It's the main one, the big one.
I got to 1.7 also.
So despite the slow start that we had earlier this semester, will we pretty much finish on time?
We should. We should. Alrighty, everyone signed in?
No.
Who has the sign-in sheet?
Me.
Okay, please. Please. There's a sign-in sheet going around. Alright, okay, so it's been crazy. There's very, very much truth to that. I know, like I said, hello, you're fine. we are doing our best to catch up, and I know the beginning was the rocky start, but for the most part, we should be right on track. I did wanna touch base on chapter 1, cause I had quite a few of you who got confused with the assignment, which flabbergasted me at the same time. But I'm gonna kind of review what was missed, so we can kind of comprehend what chapter 1 was about, okay? As far as that, before I do that, a couple of announcements. You do have chapter 1, your exam due this Sunday, okay? Please don't forget about it, okay? It is in, your chapter 2 module, okay? Your chapter 1 exam is due on Sunday, okay? This is in addition to what you're responsible for this week for chapter 3, which includes your exercise and your chapter 3 exam, okay? So you're gonna have 2 exams, okay? Chapter 1, if you haven't already done chapter 1. Chapter 1 and chapter 3, okay? They're due this Sunday, okay? And you have your chapter 3 exercise. As far as your quizzes and your exams for Honor Log, your books are allowed. If you've got any flags, I do not know why, okay? The only thing that I can think of is that you need to make sure you are within the frame of your camera, okay? For the most part, the settings do allow your books, so you should not be flagged for using your books. If you are, let me know, or let the robot or the proctor who's obviously looking at your exam, let them know, hey, our instructions are to use your books, we're allowed to use it, okay? I don't know if there's somebody who's with you at the same time reviewing it, but I'm getting that feel. So, if anything, just be mindful of what you're saying, doing. For the most part, from me as your instructor, if I don't see any concerning flags, it'll be fine, okay? So please make sure, again, you are staying within the frame. You are obviously paying attention to your quiz or exam. I know we do have family around, we may have conversations here and there, but please limit it as much as possible so you don't get flagged, okay? What else was there? The flags, your exams, remind me, what else did we talk about?
Extra credit.
Extra credit, okay, if you were not here when I mentioned it, there will be extra credit, okay? It is already open, but there are instructions, okay? That's another thing, all of your assignments have instructions. If they are not clear, or you're overthinking them, that's gonna be a no-no, okay? They should be pretty cut and dry. I know the instructions were pretty flipped for whatever reason on one of your assignments, and a lot of you got confused. So, for the most part, do not overthink, okay? Do not overthink your instructions. If they tell you this, do it as this, okay? As far as extra credit, you will have extra credit. The extra credit is you completing all your check your understandings and your exercises within your work, okay? So chapter 1 has 1.1 through 1.12, check your understandings, plus your review exercises. They may be similar to the assignments that you're already doing, but you will get extra credit if you do them, okay? I have the extra credit open to the end of the semester, because here's the little tidbit. You're only gonna upload one file with all of your extra credit, okay? So, for example, you open a Word document, you complete all of the understandings, your exercises, you take pictures of them, you put them in your Word document. Chapter 1, pictures. Chapter 2, pictures. Chapter 3, pictures, okay? If you wanna do pictures, you can enter the answers yourself, but you must complete all of your understandings and your exercises for full credit. Does that make sense? Yes? Okay, so I think we're doing, I think about 12 chapters, so we should have 12 chapters of, understandings and exercises if you want the extra credit. Okay. Excuse me, okay?
How many points is this?
TBA. TBA, okay. But it will be worth your while, okay? Again, only one file, okay? I did, provide you 2 attempts, but you should only submit 1 file, okay? It doesn't have to be Word document. If you are tech savvy, you can do PDF, what have you, okay? But it is open, it'll stay open till the end of the semester, because you'll have time to do all of the chapters we go over, okay? Any other questions regarding extra credit? Nope, okay. Okay, remember we said chapter 1, chapter 3 exam is due this Sunday plus your chapter 3 exercise. For those of you that are just coming in, if you get flagged, you can disregard it. Just please make sure you are staying within the frame of your camera. You're avoiding any unnecessary conversations, and again, you can use your books for your quizzes and exams. Remind me, am I missing anything else? No? Okay. I think that's good for now. Before we move on to chapter 3, again, I do want to go over chapter 1 because, like I said, I don't know what happened, guys. I don't know what happened. I don't know if you guys panicked when you didn't get automatic feedback, and I think that's what happened. Because again, there were instructions on there, but for the most part, some of you added extra blanks. Some of you omitted commas, so it didn't correct it the way it should have. So that's why the manual review was done, okay? I'm gonna go over a couple of them. I know we did the first couple of them as well in class. Anybody else need to sign in? Nope. But for the most part, chapter 1, your diagnosis coding is the most important one, because if you are in the other class, you've seen that it is, they go together, okay? Any questions before I review our 1.5 assignment? Okay, after this, we will go on to chapter 3, okay? All right. This was the first one, the subacute endomyometritis. Thank you. The assignment was to identify the main term within that statement, okay? So I know from this one, you would go to endomyometritis and it would send you somewhere else, right? You guys were using that other term. We were looking for the one in your statement, which was endomyometritis, okay? Some of them had 2 codes versus just the 1 code, like the rheumatic pneumonia. Your main term was pneumonia, and you had your I00 and then your J17.
Is it supposed to be? Oh, okay, sorry.
This other one, osteoarthrosis, both hips. You guys were doing osteoarthritis. There is a difference, okay? Please be careful, especially when you are coding. That already, if you had submitted an official claim, that would have been a flag on that claim. Because if the doctor is telling you osteoarthrosis versus osteoarthritis, they're gonna say, hey, we don't have the documentation to match it, okay? So please be careful. Also spelling, okay? Some of you were missing the R, some of you were missing the O. Please make sure you are focusing on your spelling as well, okay? Cervical intervertebral disc prolapse. What was the main term?
Prolapse.
Prolapse, okay? Remember, we were looking in the alphabetic index for the condition, for the disease, which is prolapse, okay? Stenosis of cerebral artery. What was your main term? Stenosis, okay? Because cerebral doesn't work. Artery doesn't work if you're looking, if you're looking for that condition in your alphabetic index. Early onset Alzheimer's disease. There was only 1 term for this, which was? Disease, okay? This one required your 2 codes. Your disease is your main term, and your G30.0 and your FO2.80, okay? So that one required 2 codes. This other one, meningitis and bacterial disease. We're gonna look in the book for this one because a lot of you have trouble with this. So we're gonna go to meningitis in your alphabetic index.
I have a question. When it's 2 terms, you don't want them in like parentheses or brackets, you just want commas?
So the way that it's set up is that they just have it with commas. If you add it because the book shows you that, you still got credit for it. Okay. But if you saw in the instructions, it told you to just use commas, but again, that's where the manual review came in, okay? So we're doing meningitis, okay? Meningitis in your ICD-10 book.
That's on page 233.
Yes. There, meningitis in your ICD-10 CM book, your alphabetic index. All right, meningitis in bacterial disease. Okay, that is your statement. So you go to meningitis, you see that there's no entry for bacterial, there's no entry for disease. But if you go all the way down to in, okay, and then it has your non-essential modifier due to, That's where you were looking at. So meningitis, in due to, you see bacterial disease. How many codes do you have there? Two. Your A48.8 and your G01. Those were the codes for that particular statement. Okay? So again, please make sure you are reviewing the statement in its entirety to make sure you are capturing all of the condition. Okay? Any questions on that one? No? Alright. Aspiration pneumonia, what was your main term for that?
Pneumonia.
Alright. Nutritional polyneuritis, what was your main term?
Polyneuritis.
Polyneuritis, that one also required 2 codes. Let's go to polyneuritis. Are we on polyneuritis? Polyneuritis, we're looking for nutritional. If you see there on 270, the third column, you have polyneuritis. If you go down alphabetical order, you have nutritional. And how many codes do you have there? 2. E63.9 and G63. Okay. Any questions so far? Okay, the next one. Ankylosing spondylitis with lung involvement. What is our main term?
Spondylitis.
Spondylitis. Let's go to spondylitis. Remember, this is different from spondylosis or spondylolisthesis. We're looking for spondylitis, okay? Again, be careful with your medical terminology. Spondylitis. Are we on 303? Spondylitis. We have the ankylosing. You have there your entry, your subterm ankylosing, and we're looking for lung involvement. What is that first line with lung involvement? What codes do you have there? Correct. Okay? Did we get that one? Yes? Alright. And the other ones were essentially the same thing. We were looking for the main term and your code or codes if it required 2. So acute sigmoiditis, what is your main term?
Sigmoiditis.
Sigmoiditis, and you had K52.9. Okay? Abdominal hernia, what is your main term?
Hernia.
Hernia, K46.9. Okay, this is another one we're gonna look at. Cholesteatoma. Cholesteatoma. Let's go to cholesteatoma in your alphabetic index. Remember to be careful with your terminology for this one as well. For cholesteatoma, okay, we have our left ear. So we have cholesteatoma. What is your non-essential modifiers there? Ear, middle with reaction. So we're looking at H71.9. Remember, this is our default code. Because we have that dash there, that's telling us we need another code to complete it. So we're gonna go to H71.9 in your tabular. Okay, H71, and then we have our H71.0, .1, .2, .3, .9, okay? Your unspecified cholesteatoma, and we have the left ear. You have .90 for unspecified, .91 for right ear, .92 for your left ear, and .93 for your bilateral. So what is your code here? 92, correct, okay? Do we understand how we got that one? Yes? All right. All right. And we had the idiopathic dystonia. What is our main term? Dystonia. Your code was G24.1. Okay. Your last one, acute necrotizing myopathy. What is your main term? Myopathy. Your code is G7281. Okay. I know we're still looking at our book. Do we have any questions? No. We're positive? You sure? I see faces. I see faces. We understand it now, right? And always remember, anytime that you are looking at your diagnosis in the tabular, we're also referencing our guidelines and our chapter-specific guidelines, which we'll talk about for our next chapter. But again, any other questions before we move on? Nope? Okay, so we're gonna move on to chapter 3, okay? Excuse me, chapter 3. So this is where our ICD-10 CM coding guidelines are gonna come in handy, and you have those available on Blackboard, but we're also gonna follow along with the book, okay? Chapter 3 is your intro to the Uniform Hospital Discharge Dataset and your official ICD-10 CM coding guidelines, okay? You can follow along with the slides, or you can follow along with the workbook, okay? Alright, chapter 3, here are our learning objectives. I won't go through those, but you guys can do that on your own. You have your abbreviation, your UDS, UHDDS. What does that stand for? Uniform Hospital Discharge Dataset. Please remember that, okay? Your Uniform Hospital Discharge Dataset. It is your minimum common core set of data, originally intended for acute care, short-term hospitals, okay? Anytime you are looking at this abbreviation, think about the Uniform Hospital Discharge, okay? Think of inpatient, okay? Think of the acute care, short-term hospital stay, okay? It's gonna be a difference when it comes to outpatient, okay? So Uniform Hospital Discharge set, and then you'll have your ICD guidelines for inpatient and outpatient, okay? You have the application of UDS definitions has been expanded to include all non-outpatient settings. There it is again. The UDS is all non-outpatient settings, okay? Which includes acute care, short-term, long-term care, psych hospitals, home health agencies, rehab facilities, nursing homes, and such. So what did we say? UDS is inpatient or outpatient? Inpatient and all these other settings that qualify, okay? So please remember that your UDS does not apply to outpatient, okay? UDS does not apply to outpatient, and please remember the abbreviation and the full term of your UDS, okay? Your UDS definition is also on page 91, there it gives you the same thing. UDS was promulgated by the U.S. Department of Health, Education, and Welfare in 1974 as a minimum common core of data on individual acute care, short-term hospital discharges in Medicare and Medicaid programs, okay? Remember that, okay? Non-outpatient is UDS, okay? You have your UDS data elements, specific items regarding patients and their care. This is also on page 92, okay? Part of the current UDS includes the following specific items pertaining to patients and their episodes of care, which include their personal identification number, their health record number, their DOB, their sex, their race, ethnicity, their residence. You also have healthcare facility ID numbers, admission data and type of admission, your discharge date, your attending physician identification, your surgeon identification, the disposition of patient, and the expected payer, okay? So please understand that these are the elements for UDS, okay? Remember we said non-outpatient, okay? All of these elements are part of UDS, okay? And here it goes on to say the same ones we covered. Remember, this is on page 92. They're all the elements are pretty much straightforward. Your personal ID is, again, your medical record number or whichever number they're using to identify the patient name, your date of birth, gender, your residence. Here they're asking for the zip code. Healthcare facility ID number is the unique number assigned to each institution. The admission data or the type of admission, your discharge date, attending physician ID, again, the unique number assigned to each physician, your surgeon ID, the disposition of the patient, the destination of the patient upon leaving the hospital. Are they discharged home? Did they leave AMA? Are they discharged to another hospital, another short-term or long-term Did they die, or what happened? What was the disposition of the patient? And then obviously your expected payer, the single major source expected by the patient to pay for this bill, for example, Blue Cross Blue Shield, CMS, workers' comp, what have you. All right, here we have more information. Clinical information is part of UDS. All diagnoses affecting the current hospital stay must be reported. All significant procedures, dates, and the person performing the procedure must be reported. The definition of principal and secondary diagnosis and procedure is included in UDS. So you're saying, well, what does this all mean? If you look on page 92 and 93, you have the rest of these elements here. Again, here, in keeping with the UDS standards, medical data items for the following diagnoses and procedures are also reported. Please remember the following, okay? Your diagnoses, again, that's all the diagnoses affecting the current hospital stay. Again, they must be reported as part of UDS, okay? Remember, this is non-outpatient, so any diagnosis that transpired within the week stay or the 2-week stay or what have you, all of those have to be reported. Your principal diagnosis, okay? The principal diagnosis is designated and defined as a condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care, okay? Please remember these definitions. Your diagnosis, your principal diagnosis, again, your principal diagnosis is designated and defined as a condition established after study, okay? Which means what is the reason, what was the condition for that hospital stay, that admission, okay? Other diagnoses, these are designated and defined as all conditions that coexist at the time of admission that develop subsequently or that affect the treatment received or the length of stay. Diagnoses are to be excluded that relate to an earlier episode that has no bearing on the current hospital stay. So let's say the principal diagnosis is a myocardial infarction, but this patient also has hypertension, diabetes, any other comorbidities. Those would be considered other diagnoses, okay? You also have more information on page 93, but we're gonna move on to complication, okay? Complication. A complication or comorbidity is defined as additional diagnosis that may have an impact on the payment received through the MSDRG, which is your Medicare Severity Diagnosis Related Group, Inpatient Acute Care Prospective Payment System from Medicare, okay? The MSDRG is part of your inpatient stays, which we won't talk a little bit too much about that, but understand the definition as well. MSDRG, your Medicare Severity Diagnosis Related Group, okay? So again, our complication is defined as an additional diagnosis that describes a condition arising after the beginning of a hospital observation and treatment, and then modifying the course of the patient's illness or the medical care required, okay? Your comorbidity, this is defined as a pre-existing condition, okay? Your pre-existing condition that, because of its presence with a specific principal diagnosis, will likely cause an increase in the patient's length of stay in the hospital. Let's say for whatever reason the patient was admitted for dehydration, but then it turns out that they also have the dehydration was because of their chronic kidney disease, but then let's say what can we put? Part of the chronic kidney disease, they had the hypertension and the diabetes as well, so that would be part of those comorbidities. Your procedures and your dates, this is still on page 93, procedures and your dates. All significant procedures are to be reported. For significant procedures, both the identity of the person performing the procedure and the date of the procedure must be reported. So you're asking, what is the identity? The identity is the unique number within the hospital, who usually is the NPI of that provider, that surgeon, or who have you. But again, please remember, all significant procedures are to be reported. You need both the identity of the person performing the procedure and the date of the procedure must be reported. I'll give you an example as to why this is important. Let's say your patient is admitted, they stay for a week. Let's say they do, for whatever reason, they do a craniotomy within that visit stay. How are we gonna know when exactly they did that craniotomy if they don't report it? Okay, so please make sure you understand that element as well. As far as significant procedures, please remember these as well. A procedure is identified as significant when it is surgical in nature, carries a procedural risk, carries an anesthetic risk, and requires specialized training. Okay, this is still on page 93. Your significant procedure, okay, your significant procedure has to have these elements. Is surgical in nature, carries a procedural risk, carries an anesthetic risk, and requires specialized training. Okay, please remember those elements. Remember, we're still talking about inpatient, okay, or UDS, okay? Bless you.
Thank you, sorry.
Any questions so far? Nope, okay. Then we have our principal procedure, still on page 93. Our principal procedure, the procedure is performed for definitive treatment rather than for diagnostic or exploratory purposes, or is necessary to take care of a complication. If two procedures appear to be principal, the one most related to the principal diagnosis should be selected. Let's say, for example, the patient comes in, they have a CDs and they're doing a, what is the term I'm looking for? What was it? Yes, but there's a specific term.
Dialysis?
No, abdominocentesis. When they have a CDs and they do an abdominocentesis, I hope I'm right. Let's say that was the reason they came in, but then also during their stay they did a, I don't know, let's say they did a, what's another one? Why am I blanking? They added a catheter for urinary, whatever problem that they had. So remember, the reason why they came in was for the ascites. So the principal procedure that we're reporting would be the abdomen, what did I say?
Abdominocentesis.
Abdominocentesis, okay? We kinda get that example? Yes, more or less? Again, just think about it the same way, the principal procedure. What was the main procedure done, that coincides with the reason that they were admitted, okay? On page 93, you also have the same definition, the type of procedures performed for definitive treatment rather than for diagnostic or exploratory purposes, or obviously when it is necessary to take care of a complication, and it tells you the same thing. If two procedures appear, the one most related to the principal diagnosis should be selected as the principal procedure, okay? All right, here's the same definition for your principal diagnosis. The condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Principal diagnosis relates only to inpatient care. Remember that, okay? Principal diagnosis relates to inpatient care. You may hear that outside in the outpatient world, but understand that it varies when it comes to inpatient and outpatient, okay? On page 94, you have there that section selection of the principal diagnosis. Here they give you an example. Patient was admitted through the ED with an admitting diagnosis of seizure disorder. During the hospitalization, diagnostic tests and studies revealed a carcinoma of the brain, which explained the seizures. The principal diagnosis here is the carcinoma of the brain, which was the condition determined after study. Okay, do we get how the principal diagnosis applies now, right? Okay, there's another example. This one tells you, at times, however, it may be difficult to distinguish between the principal diagnosis and the most significant diagnosis. Here it goes on to tell you, the most significant diagnosis is defined as the condition having the most impact on the patient's health, their length of stay, their resource consumption, or any related things. However, the most significant diagnosis may or may not be the principal diagnosis, okay? Please remember that. Your most significant diagnosis may or may not be the principal diagnosis. You have an example. Patient was admitted with a fractured hip due to an accident. The fracture was reduced and the patient was discharged home. Here, the principal diagnosis was the fracture of the hip, okay? You have the other example. Patient was admitted with a fractured hip due to an accident. While hospitalized, the patient suffered a myocardial infarction. In this case, the principal diagnosis was still the fracture of the hip with the myocardial infarction coded as an additional diagnosis, okay? Although the myocardial infarction may be the most significant diagnosis in terms of the patient's health and their resource consumption, it was not the reason after study for the admission. Therefore, it was not the principal diagnosis. With those examples, are we still on the same page? Yes? Okay. All right, so remember, principal diagnosis versus most significant diagnosis, okay? All right. Okay. So that was mainly, never mind, I will, as I spoke too
I
soon.
have a quick question.
Yes.
So if they would have had a myocardial infarction and it caused them to have the accident and fractured their hip, then the principal diagnosis would be the myocardial.
It would depend, if they found out that if they were able to timestamp that the MI happened before the fracture, then yes. But again, that's because they're doing the studies. So that's the key word, after the study. Okay? So if they're able to determine after they run their tests and all that stuff, then that would be different. Any other questions before we move on? No? Okay. All right, so our ICD-10 CM official guidelines for coding and reporting, we have there at the bottom of 94, and it continues on through page 95. Your official guidelines are developed by the AHA, AHIMA, CMS, and NCHS, and you have several sections for your coding guidelines. I will emphasize here before I move on that you have coding guidelines for inpatient care and outpatient care, okay? They're essentially a 2-in-1 in that file if you pay attention, but there are different guidelines for inpatient and outpatient, okay? Do not get them confused, okay? You'll see a couple of examples. Section 1, you have your structure and conventions. Remember, your conventions are above any of your chapter-specific guidelines. Those are the ones you should follow first before you follow any chapter-specific guidelines. Structure and conventions of ICD-10-CM and the general guidelines that apply to the entire classification system. These are the fundamental coding rules for assigning ICD-10-CM. I'm going to quickly show you here on our PDF file. Also, do not get your coding guidelines confused with PCS, because those also have coding guidelines. We're talking about our diagnosis, okay? We can move past the PCS. Where are our... Okay, so our 2025 fiscal year guidelines here. I know the print is kind of small. Okay, remember, there's those 4 organizations that we said, your American Hospital Association, AHIMA, CMS, and NCHS. Here is this point that we're making. The instructions and conventions of the classification take precedence over guidelines. You're asking, well, what are the instructions? What are the conventions? If you look a little bit down here, you have section 1A, which show your conventions of ICD-10-CM, which include your index, your tabular, your format and structure, the codes, the placeholder, your 7 characters, abbreviation, punctuations, your includes notes, your excludes ones, and with CC also code, also default codes, and your code assignment. So this first section, section 1, these are gonna be your holy grail for any of your diagnostic code, okay? You need to look at these before you look at any of the chapter-specific guidelines. And when I say chapter-specific, if you look at your book, go to one of the chapters in the tabular. Let's see which one we can find out first. If you look on page 963, this is your congenital section, chapter 17, 963 in your ICD-10. you see how you have the beginning of your chapter, you have your notes, your excludes two, and you have your chapter specific coding guidelines, okay? So let's say you're coding something from this chapter. Please make sure you are referencing your conventions in your ICD-10 guidelines PDF before you look at these, the ones on this page. Does that make sense? We're looking at our conventions, which are our holy grail, before we look at our chapter specific guidelines. Yes? We all on the same page? Yes? Okay. So please remember that. Please remember your conventions take precedence over your chapter specific guidelines. Let's go back. Alright, that was section one, okay? Section one was your convention. So again, we said our conventions are our holy grail. Section two, these is particular to inpatient, okay? Section two is your principal diagnosis selection for inpatient care. In determining the principal diagnosis, the coding conventions in ICD-10-CM tabular index take precedence over all other guidelines. The importance of consistent, complete documentation in the medical record cannot be overemphasized. That is absolutely 100% on the nose, because again, we as a coder, or whatever your title is, if you are looking at the codes, we cannot code anything without the documentation, okay? We cannot code without the doctor literally telling us they had subdural hematoma, we did this craniotomy. We cannot assume, oh, they do have a subdural hematoma, but the imaging says otherwise and all that good stuff. We can only go based off what the doctor is literally telling us, what they're diagnosing, what they're treating, okay? So again, this is where the medical record, the progress note, the actual notes of the doctor, the PA, or whoever the surgeon is transcribing, is documenting, that is our main source of information when it comes to finalizing the codes we add to our claims, to our coding system, or what have you, okay? So, again, the documentation is the utmost important part of coding, okay? Any questions so far? We are on section 2 of our official coding guidelines and reporting. On page 95, you have another example of your principal diagnosis. Patient was admitted to the hospital with chest pain to rule out myocardial infarction. After study, okay, after they ran all their tests and they did all their studies, myocardial infarction was ruled out. The cause of the chest pain was undetermined. So this not only also applies to your principal diagnosis, but also applies for that particular section 2A guideline, which is codes for symptoms, signs, and ill-defined conditions. On page 95, you have there codes for symptoms, signs, and ill-related conditions from chapter 18 are not to be used as a principal diagnosis when a related definitive diagnosis has been established, okay? So your guideline is telling you that our codes should not be used unless there is a confirmed condition. If you look back at your example, they were admitted for chest pain, they ran their tests, they said, okay, we don't know what caused the chest pain, we know for sure it is not an MI, okay? So we can still use the guideline here and use the R code, okay? Because the R code for the chest pain is R07.9, okay? Did I lose any of you? Okay? So again, this is where your guidelines are gonna get a little bit tricky, but again, this is where you always have to reference them. So again, our guideline says codes for symptoms, signs, and ill-defined conditions unless there is a definitive diagnosis that has been established. So again, in that case, because we could not determine what caused the chest pain, we can code the chest pain. Yes? Yes, okay. There's another example here. Patient was admitted to the hospital with dysphagia secondary to a malignant neoplasm of the esophagus. A PEG tube was inserted. Okay, so again, patient was admitted with dysphagia secondary to, you can also consider that as due to malignant neoplasm of the esophagus. So the reason why they were having the dysphagia is because of that tumor, that cancer of the esophagus that they have. So if you read on, it says code C15.9, which is your malignant neoplasm of the esophagus unspecified, was selected as a principal diagnosis versus your R13.10, which is for the dysphagia. Again, because the dysphagia was related to the malignancy, and code R13.0 is from chapter 18, which again tells us in that guideline that the principal diagnosis has to be the definitive diagnosis. Okay? These examples should be pretty cut and dry. If you are confused, please let me know. Okay? Any questions? Nope? Okay, we'll move on. There was the 2A and 2B. 2B, your guideline 2B, two or more interrelated conditions, each potentially meeting the definition for principal diagnosis. So if you look on page 96 in your textbook, in your what do we call it? Workbook, thank you. In your workbook, you have guideline 2B, two or more interrelated conditions, each potentially meeting the definition of a principal diagnosis. When there are two or more interrelated conditions such as disease in the same chapter or manifestations potentially meeting the definition, either condition may be sequenced first unless the circumstances of the admission, the therapy provided, the tabular risk, or the index indicates otherwise, okay? So again, if you have two or more interrelated conditions and you can't figure out which one is principal, you're gonna apply this guideline, okay? The example that they gave you. Patient was admitted for initial treatment for a closed fracture of the right femur lower end and fracture of the right tibia upper end. The following diagnoses were applied. Your S72.401A for your fracture of the femur, S82.101A for your fracture of your tibia. Both fractures potentially meet the definition of principal diagnosis. Therefore, either code should be sequenced first. So there, it's giving you the option. You can either code one or the other because again, the documentation is telling you that they're interrelated. If it told you the fracture of the femur was related to a car accident versus the fracture of the tibia was pathologic, then that changes the game because one is traumatic, one is pathologic, okay? That was 2B for our guideline, okay? 2C, two or more diagnoses that equally meet the definition for principal diagnosis, okay? We're still on page 96 of your workbook. In the unusual instance when two or more equally meet the criteria as determined of admission, diagnostic workup, and or therapy provided, your index, your tabular, other coding guideline does not provide sequencing direction in such cases, any one of the diagnoses may be sequenced first. So again, this guideline is telling you what to do. Here's the example. Patient was admitted for elective surgery. A lesion on the left breast was excised and revealed fibroadenosis of breast. In addition, a right recurrent inguinal hernia was repaired. The following diagnoses were assigned. Your N60.22 for fibroadenosis of the left breast and K40.91 for your unilateral inguinal hernia without the mention of obstruction or gangrene. And then there's your recurrent. Both the fibroadenosis of left breast and the right recurrent inguinal hernia met the criteria for principal diagnosis. Therefore, either condition could be selected as principal diagnosis. Okay? Any questions so far? Nope. Okay. I'm open the door. If you are confused, speak now and forever hold your peace. Okay? Because I don't want to hear at the last minute, ma'am, I didn't understand the exercise. And then at the last minute I say, what were your questions in class? What were your questions beforehand? Okay? Whenever you send me questions, I don't mind them, but again, do it timely. Okay? So that was guideline 2C. Guideline 2D, two or more comparative or contrasting condition. In those rare instances when two or more contrasting or comparative diagnoses are documented as either or similar terminology, they are coded as if confirmed and sequenced according to the circumstances of the admission. If no further determination can be made as to which diagnosis is principal, either diagnosis may be sequenced first, okay? So do we get the concept of our guidelines? If we have certain situations, our guidelines are telling us which one we need a code, which one goes first, so on and so forth, right? Okay. For that example, for your guideline 2D, you have diverticulosis of the large intestine versus angiodysplasia of the colon. That's your diagnostic statement in the note you're looking at, right? That's what the doctor wrote. They're telling you it could be either or. They use the term versus, okay? Here with this guideline, it's telling you codes K5730 for diverticulosis and K55.20 for your angiodysplasia are both assigned, okay? Either unconfirmed diagnosis, the diverticulosis or the angiodysplasia may be sequenced as a principal diagnosis. So here it's telling you, the doctor wrote that statement, the diverticulosis versus the angiodysplasia. You can code both because again, it falls under that category, the two or more, and it doesn't matter which one goes first, okay? Because the doctor confirmed it could be one or the other. Got it? Remember, this is only for inpatient, okay? Inpatient.
So it's always the doctor that confirms if they're, so
The
that's not
doctor-
our,
Yeah, it's not gonna be up to you as a coder, it's gonna be up to the doctor. You have to depend on them to tell you, it definitely is this one, or it definitely is that one. If you encounter in an inpatient setting where the doctor tells you it's versus, or it can be either or because their studies or their treatment didn't
definitively.
didn't define what was essentially wrong with them. Because of that guideline, because of their documentation, we can pick up both. However, in the outpatient setting, it's a little bit different, okay? But I won't get too far into outpatient. But please remember that these apply to inpatient, and we strictly depend on the doctor to tell us. We cannot assume, we cannot guess, even though we might say, oh, well, this pathology showed this, or this other note showed that. No. The doctor said it's this versus this, you take their word for it. Okay, remember, they're the clinician. They're the ones that are treating the patient. They're the ones that are diagnosing them. Even though we have all of these codes at our disposal, we never assume. Okay, we never assume. Okay, that was a good question. Any other questions before we move on?
So it's either or both diagnoses.
So for this guideline, you're gonna code both.
And then for the other ones that we're going through, like, C and D, it was either or
For B, you have, there it tells you, again, the same thing. You can code both, but depending on the sequencing, that may apply as well. So again, just pay attention to each of the guidelines because they may be different, but understand that anytime you're reviewing the documentation and you're not sure, your whole point is to go back to your guidelines to tell you, okay, which one am I coding first, which one am I not coding, or what have you.
So the book holds your hand, in other words.
Yes, never stray away from anything, oh, wait, but I think this happened, or that happened. No, if your book strictly tells you, you have to take it for face value, okay? Don't overthink it, especially with the coding, because there are some instances where, let's say, you code it one way, and then she codes it another way. But then who's following the guidelines? You know what I mean? So always the guidelines. Your guidelines are your Bible, essentially.
For C, when it said elective surgery, and it was the breast and the inguinal hernia, they're in two different spots. So, how would we, like, it says like either one could be because they're both at the same, is it because they're both being done at the same time? Is that way they can be coded at the same?
So let's look at the guideline again. In the unusual circumstance when two or more diagnoses equally meet the criteria for principal diagnosis as determined by the circumstances of admission, your diagnostic workup, or the therapy provided, your index tabular, what have you, does not provide sequencing direction. In such cases, any one of the diagnoses may be sequenced first. And then you have your example. Was admitted for elective surgery, which was the lesion of the left breast was excised and revealed the fibroadenosis of the breast. In addition, a right recurrent inguinal hernia was repaired. Let's say for whatever reason they found that hernia when they were in the breast, or however which way they cut it, right? If they found it within that same setting, even though, that was not the main reason they did the surgery, but because they kind of did, it was part of their care, essentially, because they found it, you would still make it up. Does that make sense?
Yeah.
Yes, so again, it just depends, cause you'll encounter so many different scenarios that you're like, wait, is it this one or is it that one? So this is where you reference your guidelines always. Any other questions?
So where we look in the tabular, like you were saying, well, I don't know what color it was, like the orange or whatever, says chapter 17. And we got two different codes from there. Do we go to chapter 17, the guidelines to double check or?
So the ones from chapter 17 were chapter specific. So let's say your conventions don't provide you with the direction you need, for whatever reason, then you can use your chapter specific guidelines. But always reference your conventions first before you go to the chapter specific guidelines. Does that make sense?
And the conventions are the C also and with, okay.
Yes, remember, those are your main ones. Those are the ones you always have to apply, before you look at any of the instructions it tells you for each of the chapters. Okay? Any other questions? We're good on time, okay. Guideline 2C, 2D, 2D was the process, okay? 2E, oh, this one was deleted, effective, okay, so we'll skip that one. 2F,
I also saw that when we were looking up codes that some of them were deleted. Do we just?
yes, so, I know, I believe this book is based off of 2024. Always make sure you are looking at your updates, because just like this one, this particular guideline, it was deleted, effective 2014. So that guideline after 2014, does not apply, and the same goes for specific codes. There are certain codes that no longer apply to, 2025, so that's why once you become established in your position, career, whatever, whenever you're coding, always make sure you're keeping up to date with the updates, because that's when you find out, okay, these codes were deleted, these were added, they changed the description on this one, or what have you. Alright, we have F and G. Guideline 2F, original treatment plan was not carried out. And guideline 2G, complications of surgery and other medical care. Your 2F, sequence as a principal diagnosis, the condition, original plan, sorry, let me start over. Guideline 2F, original treatment plan was not carried out. You're gonna sequence as the principal diagnosis a condition which after study occasioned the admission to the hospital, even though treatment may not have been carried out due to unforeseen circumstances. The example that they give here, patient with ulcerated internal hemorrhoids was admitted for a hemorrhoidectomy. Prior to the beginning of the surgery, the patient developed bradycardia and the surgery was canceled, okay? The following codes were assigned: the ulcerated internal hemorrhoids, the bradycardia, and a Z code that the procedure was not carried out because of a contraindication. The code for the hemorrhoids was still listed as primary because it was a reason for admission, and then the additional code for bradycardia and the Z code for the procedure not carried out. So this guideline tells you that even though the procedure was not done for whatever reason, you are still going to code the reason for that procedure. So here, because they were gonna do the hemorrhoidectomy, even though they didn't do it, you are still gonna code the hemorrhoids. Okay? Does that make sense? Okay, so that one's pretty self-explanatory. The next one, guideline 2G, complications of surgery and other medical care. We are on page 97 in our workbook. Complications of surgery and other medical care. When the admission is for treatment of a complication resulting from surgery or other medical care, listen here, the complication code is sequenced as the principal diagnosis. If the complication is classified to the T80 through T88 series and the code lacks the necessary specificity in describing the complication, an additional code for the specific complication should be assigned. So again here, they said if there is a complication and that's the reason they're going in, the complication code is When admission for the treatment of a complication resulting from surgery, the complication code is sequenced as the principal diagnosis, okay? In the example, they told you, patient was treated for an atelectasis due to a recent cardiovascular surgery. The diagnosis would include the J9589, which shows the other post-procedural complication of the respiratory system, and J9811 for the actual atelectasis. So you have your post-op complication code, the actual post-op condition, and that's it. So then, for this one, so this particular example, you have two codes, because again, you're coding the actual complication, but then you're actually coding the condition. So here they said they were treated for the atelectasis due to a cardiovascular surgery. So that means that there was that complication of the cardiovascular surgery, and there you have the treatment for the atelectasis, okay? Do you have any questions on that one? I know these get a little bit tricky, but remember, we're still on inpatient, okay? We're still on inpatient. All right. Guideline 2H and 2I, uncertain diagnosis and the admission following a medical observation and following a postoperative observation. Guideline 2H, you have uncertain diagnosis, okay? Please pay attention to this one, because this one applies to inpatient, okay? If the diagnosis documented at the time of discharge is qualified as probable, suspected, likely, questionable, possible, or still needs to be ruled out, compatible with, consistent with, or similar terms indicating uncertainty, code the condition as if it existed or was established. The basis for these guidelines are the diagnostic workup, the arrangements for further workup, and any of the initial therapeutic approaches that corresponded most closely to the established diagnosis. Note, this guideline is applicable only to inpatient admissions to short-term, acute care, long-term, and psych, okay? So again, if your discharge summary tells you it was, let's say it was a questionable myocardial infarction, what is this guideline telling you to do?
To use it as a.
To code it as if it actually, it was actually confirmed, okay? But remember, this is for inpatient. I will tell you right now, when you see these terms in outpatient, you do not code them, okay? So this is the difference where I tell you to be careful with inpatient and outpatient. Inpatient, if you see these terms for an uncertain diagnosis, it's telling you to code them, right? But if you see them in an outpatient, in an office visit, you cannot code those, okay? In outpatient, you would use the guideline of the signs and symptoms if there was no confirmed diagnosis, okay? So this is one of the big ones that you need to know, that is different from inpatient and outpatient, okay? And especially any of these terms that you see, suspected, likely, questionable, consistent with, or any of the similar terms indicating uncertainty, okay? So please make sure you are looking at these guidelines anytime you have any of these potential descriptions for that diagnosis, okay? All right, guideline 2I, we have admission from an observation unit, and then we have the admission following the post-op observation. For the observation, the medical observation, when a patient is admitted to an observation unit for a medical condition which either worsens or does not improve and is subsequently admitted as an inpatient of the same hospital for the same medical condition, the principal diagnosis would be the medical condition that led to the hospital admission, okay? I know that was a mouthful, but again, pay attention to the difference between the medical observation and the post-op observation. For the post-op, when a patient is admitted to an observation unit to monitor a condition or complication that develops following outpatient surgery and then is subsequently admitted as an inpatient of the same hospital, hospitals should apply the UD's definition of principal diagnosis as that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. So again, if, let's say for that post-op observation, let's say they went in and had a same-day surgery for their hernia. Let's say they were repairing the hernia. But then, let's say, what could be a complication? Let's say they developed an infection to the site or what have you. Again, this is where you would apply your definition to consider what was the condition established after study to be chiefly responsible. And now that I read it out loud, I take that back. That was a bad example.
What if something's left in the body, would that be considered like a full stop?
Yes.
Sometimes they have like for the pain management.
Uh-huh. Yeah, so, I think this one's kind of,
Or maybe
Vague.
like under blood pressure.
right. This one would be a little bit, it's kind of a wishy-washy if you don't have your actual note in front of you, but, the only thing I can tell you is without overthinking anything, pay attention to the documentation. Obviously, if it is a complication, again, if the doctor is not telling you it definitely is a complication from yesterday's surgery or what have you, then it's kind of up in the air as well. So this is where, again, we say documentation is absolutely important, because if they tell us patient is coming in for uncontrolled hypertension due to yesterday's surgery, then obviously we have the confirmation. This is definitely a complication. If they just tell us patient is coming in for uncontrolled hypertension, oh, by the way, they had a surgery yesterday. You don't know if they're related, right? So then you code it differently. You would code I-10 versus whatever post-op complication hypertension could get. So again, this is where I can only stress your absolute documentation. So I know some of these don't make sense because we don't have the actual examples, actual notes to go by. So again, anytime you are coding inpatient, please absolutely reference your guidelines, okay? They will not steer you wrong. They might confuse you, but they might not steer you, they won't steer you, okay? Any other questions? There are a lot of guidelines, if you haven't seen already, if we go back to this PDF, there are several sections. You have section 1, and part of section 1 you have A, you have B, you have C, you have all your chapter 1s, and this is where I'm gonna tell you, you have section 2 of your principal diagnosis, your 3 reporting additional diagnosis, 4, okay, so this is where, again, when it comes to outpatient, you have a dedicated section for outpatient. Please make sure whenever you are reviewing, your guidelines, you don't get them confused, especially like the uncertain one. Again, remember, if you're coding inpatient uncertain, you code them as if they were established. If you're coding uncertain outpatient, you don't pick them up, okay? So this is just a reminder that there are differences between the inpatient and the outpatient, okay? And again, if you end up becoming a coder, it is gonna be your responsibility to make sure you're reviewing them. Again, you don't have to memorize them, but make sure you understand them, okay? All right. 11J, which is admission from outpatient surgery. When a patient receives surgery in the hospital's outpatient surgery department and is subsequently admitted for continuing inpatient care at the same hospital, the following guidelines should be followed, okay? If the reason for the inpatient admission is a complication, assign the complication as a principal diagnosis. If no complication or other condition is documented as the reason for the inpatient, assign the reason for the outpatient surgery as the principal diagnosis. If the reason for the inpatient admission is another condition unrelated to the surgery, assign the unrelated condition as the principal diagnosis. So again, it clearly depends on what transpired, what they're actually going in there for. Again, this is where you strictly depend on your documentation, okay? 2K. Your 2K, still on page 98. Guideline 2K, admission encounters for rehab. When the purpose for the admission encounter is rehabilitation, sequence first the code for the condition for which the service is being performed. I give you an example. For example, an admission encounter for rehab for right-sided dominant hemiplegia following a CV infarction. Report code I-69.351, hemiplegia and hemiparesis following cerebral infarction affecting right dominant side as the first listed or principal diagnosis. If the condition condition for which the rehab service is no longer present, report the appropriate aftercare code as the first listed or principal diagnosis unless the rehab service is being provided following an injury. For example, for rehabilitation services following an active treatment of an injury, assign the injury code with the appropriate seventh character for subsequent encounter as the first listed or principal diagnosis. Another example, if a patient with severe degenerative OA, osteoarthritis of the hip, underwent hip replacement and the current encounter admission is for rehab, report code Z47.1 aftercare following joint replacement surgery as the first listed or principal diagnosis. If the patient requires rehab post-hip replacement for right intertrochanteric femur fracture, report S72141D displays fracture, subsequent encounter for closed fracture with routine healing. So this is a good example of one, again, depending on your documentation. If the patient is going in for that post-op hip replacement, you have a Z code, that aftercare. That aftercare is Z47.1. But again, depending on the documentation, you might not always have a Z code after surgery. You might have a S code depicting that fracture and the subsequent encounter, okay? We'll talk about the initial and subsequent and sequela a little bit later, but again, make sure you are looking at your documentation, make sure you are referencing your guidelines, okay? Let's see, that was continued. Okay, this is section 3, okay? Remember how we had section 3 in our guidelines over here? Okay, section 3 of our ICD-10 guidelines. This is what we're following along in our PowerPoint. Section 3, the reporting of additional diagnoses, okay? These are the conditions that affect patient care in terms of requiring a clinical eval, therapeutic treatment, diagnostic procedures, extend the length of stay, increase nursing care and or monitoring, okay? If you jump down to the middle of page 100 in your workbook, you have, for reporting purposes, the definition of other diagnoses is interpreted as additional conditions that affect patient care in terms of requiring one of the 5 factors about the patient care. These are the same 5 we just mentioned. Your clinical eval, your therapeutic treatment, your diagnostic procedures, your extended length of stay, or increased nursing care or monitoring. Okay, so another example, going back to the, let's say it was that heart attack, the MI. Let's say even though the patient was admitted for the MI, they're still treating the patient with metformin, potentially insulin for their diabetes, because it is still part of their therapeutic treatment. We can still code that diabetes. Okay, so your MI might be principal, but because of this code, we can add the diabetes to the list of diagnoses. Okay, please remember these elements, these 5 factors: your clinical eval, therapeutic treatment, diagnostic procedure, your extended length of stay, and your increased care, nursing care, and or monitoring. Okay, so again, additional diagnosis is literally that. What additional diagnosis can we add whenever we are looking at inpatient encounters? And then obviously again, confirming, are they part of the clinical eval? Are they part of the therapeutic treatment? Are they part of the rest of these factors? Okay? Diagnoses that relate to an earlier episode that have no bearing on the current hospital stay are to be excluded. I'll give you an example. Let's say the same patient, they're going in for the MI, but just yesterday they finished their treatment for a COVID infection. Okay, so they're going in after COVID, after they finish their treatment, they essentially no longer have COVID, right? So are we gonna pick up COVID in this encounter? No, no. Only because again, if it's relating to an earlier episode that has no bearing on the current stay, we do not include it, okay? So even if it's something not like COVID or something more minute, or maybe something, what can we call it?
something unrelated, okay, so unrelated.
Like epilepsy, but they're going in for something else.
Sure, yeah, so let's say they had an epilepsy, episode, they were able to treat it same day, they don't have any other signs or symptoms, we would not code that epilepsy for the next encounter of the MI. Alright, these definitions of principal and additional, diagnosis apply to inpatient settings. Again, I can only stress that, these guidelines that we're covering are inpatient settings, which include hospitals, long-term care, psych, home health, rehab, nursing homes, and other inpatient, non-outpatient settings, okay? Alright, section 3, 3A, 3B, 3C. 3A is your previous conditions, 3B are abnormal findings, and 3C is your uncertain diagnosis. We're on page 101 of our workbook. Guideline 3A, your previous conditions. If the provider has included a diagnosis in the final diagnostic statement, such as the discharge summary or the face sheet, it should ordinarily be coded. Some providers include in the diagnostic statement resolved conditions or diagnosis and status post procedures from a previous admission that have no bearing on the current state. So I'm going to emphasize this, okay? Some providers include in the diagnostic statement resolved conditions or diagnoses and status post procedures from a previous admission that have no bearing on the current state. The guideline here, such conditions are not to be reported, okay? And are coded only if required by hospital policy. So for example, let's say patient is being admitted for the MI. In the history, the doctor put resolved COVID. Because of this guideline, are we coding it?
No.
Correct. Okay, so remember, anytime we see any resolved conditions, or again, any conditions that do not relate to that specific encounter, we do not code, okay? So that was a great example. In the book, you also get an example. The base sheet states the following diagnosis: acute diverticulitis, congestive heart failure, status post cholecystectomy, status post hysterectomy. All are coded except the status post cholecystectomy and hysterectomy. The heart failure and the diverticulitis affect the current hospitalization and thus are coded. That particular example, again, we may not have all the details, but again, the theory behind it is that if it is affecting that state, if it is part of that date of service, then we pick them up. But if it's resolved or if it's completely unrelated, here they're telling you the history of the cholecystectomy and the hysterectomy, we do not pick those up, okay? 3B, your abnormal findings. Abnormal findings, which include your lab, x-ray, pathology, or other diagnostic results, are not coded and reported unless the provider indicates for clinical significance. If the findings are outside the normal range and the attending provider has ordered other tests to evaluate the condition or prescribe treatment, it is appropriate to ask the provider whether the abnormal findings should be added. Note, this differs from the coding practices in the outpatient setting for coding encountered for diagnostic tests that have been interpreted by a provider, okay? So we're gonna go over that one again. Abnormal findings, which include lab, x-ray, pathology, or other diagnostic, are not coded and reported unless the provider indicates their clinical significance, okay? In the example, in the inpatient setting, coders should not assign codes for conditions described in a pathology report alone without the provider's input. The provider or physician should be asked for clarification of the pathological findings if the provider has not documented the same condition in the health record. Let's say they went in to do, what would be a good example? What would be a good example? Let's say they went in for that hernia repair. Let's say they had something go wrong with the hernia that they had to go in for emergency surgery or what have you. let's say for whatever reason, this might be a bad example, but let's say, they biopsied whatever piece of the hernia they had, but the doctor did not make a note about it. Okay, he sent it off to pathology, he goes, no, you know what, you're fine, we don't have to worry about cancer anymore. However, even though he sent it off to pathology, pathology had a report back, let's say pathology said, oh no, it might be a minor malignancy. Because the pathology wrote it in their note, but the doctor did not mention it, we're not gonna reference it, okay? The only thing we can do is send a query. Hey doc, pathology had this report, does it apply anywhere? Did we miss something or what have you, okay? That's for inpatient. Outpatient is different, okay? If you are coding in a pathology encounter, strictly pathology, then you obviously automatically reference the pathology note. You don't have to go to their primary, you don't have to go to their specialist and say, oh, do we need to reference it? No, you automatically reference it. Do you see the contrasting differences between the two then?
The outpatient is the one that we automatically code?
In outpatient, yes, if you are coding a pathology encounter, you strictly depend on pathology. If it's inpatient that has the component of pathology, unless they mention it, you can reference it. If they don't, you may have to send a query to find out if it needs to be, what's the word I'm looking for? If it needs to be coded, okay? This is for abnormal findings, so again, please remember, this is different from inpatient and outpatient, okay? Okay, so here is this the same one? Uncertain diagnosis?
The first one is abnormal.
No, the other one, right? Too?
Yeah.
Yeah, I was thinking, that's good.
Okay, so, this just further solidifies that that particular guideline is important, because they mentioned it twice, okay? They actually mentioned it 3 times, but the 2 mentions is for inpatient and the 3rd one is for outpatient. So again, this just further solidifies anytime you have the uncertain diagnosis, please make sure you are referencing your guidelines. This one again says the same thing. In an inpatient setting, if you see any of those terms, you code the condition as if it existed. Again, if you see these terms in outpatient, we do not pick up, okay? So again, that just further solidifies the uncertain diagnosis. All right, to the nitty gritty, this is the outpatient, section 4. This is your outpatient. So again, please be mindful, the following are for outpatient, okay? Your outpatient include, your office visits, any lab, any pathology. What else do we have as outpatient? Usually those, anything that is done in a non-hospital setting, such as,
Hospice.
no, I think hospice is,
With like the cath labs and all those people that are outpatient?
cath labs?
Or no, because they're done like,
I think those are, from my experience, those were coded a little bit differently, but I don't know where they would apply in these, so I'm probably a bad person to ask about cardiac cath. Okay, but for our outpatient, this is section 4, okay, so again, these guidelines are for outpatient coding, so we said office visits, your clinics, your doctor's office, essentially your private practices, and your ambulatory care centers, even maybe potentially your ambulatory, what's the word I'm looking for? Ambulatory surgery, but don't quote me on that one. But essentially this is outpatient physician office and, clinics, okay?
oh, so these are like urgent care and stuff? Or would that be
Yes,
considered?
no, yes, urgent care, yes, cause I don't think we have specific urgent care, I think they would fall under outpatient, cause they're essentially same thing. Okay, so section 4, guidelines for outpatient coding and reporting. Coding for patient visits in hospital, outpatient physician offices. Also clarified by the coding clinic, these guidelines apply to the coding of physician services for professional fee billing regardless of the setting where the physician provided the service. Just a quick note before I move on, there is, essentially what we call pro fee coding versus, what is the other term they use? There's another term that distinguishes between the different types of coding. So essentially the professional fee coding, you're only coding for whatever the doctor does, regardless of where they're at. Versus when you're coding, kind of all of the elements together where the doctor is solely part of that particular facility. You'll end up hearing about these a little bit later, but there is, what's the best way I can tell you? There is a, what's the word I'm looking for? I don't wanna say niche. There are careers for just pro-fee coding versus, I'm trying to think of the other term, versus the other type of coding. So sometimes outpatient will be a little bit of everything, or it can be broken down to just coding for what the provider did, just coding, and then coding what the provider and the setting, the facility did. Is it facility coding? I'll get back to you guys on it, but there's a difference. Okay, so we said coding clinic, these guidelines apply to the coding of physician services for professional fee billing regardless of the setting where the physician provided the service. Guideline 4A, okay, this is for the term first listed diagnosis is used instead of principal diagnosis in the outpatient setting, okay? So remember, in inpatient, we said the principal diagnosis was whatever was determined after the tests, after the studies were done, right? Your first listed, okay, is a little bit different, the way they describe it. If you look on 102, 103, you have that section there. You have the selection of the first listed condition, okay? In the outpatient setting, the term first listed diagnosis is used in lieu of principal diagnosis. In determining the first listed diagnosis, the coding conventions as well as the general and disease-specific guidelines take precedence over the outpatient guidelines. Diagnoses often are not established at the time of the initial encounter or visit. It may take 2 or more visits before the diagnosis is confirmed. And then here they go break it down to the rules. So essentially here, there's not gonna be the principal diagnosis, they'll just call it the first listed. So a good example I can give you is at the VA, we see the office visits, right? Let's say the veteran is going for their follow-ups, but they address diabetes, hypertension, allergic rhinitis, and all these other essentially comorbidities, right? Just chronic conditions. There's not really a, what can I tell you, a pinpointed reason for the visit unless the doctor tells you, right? If they're just saying, well, we're just here for a follow-up to look at the chronic conditions, then you obviously look at the conditions you have. If they have a list of the diabetes, hypertension, there's not really a rule as to which one is the principal diagnosis. Here would just essentially be what's the first one that they talked about. So in this case, let's say you have your SOAP note, your chief complaint says patient is here for follow-up on chronic conditions, diabetes, hypertension, XYZ. They do their assessment, they do their plan, their physical exam, and then in their A&P they list diabetes, hypertension, but in there's no reasoning for that potential order. It's just whatever conditions that they have, right? So then here, there's not really a wrong or right way to code those chronic conditions. It would just be, okay, if doctor said, they address the diabetes first, well then your diabetes first, okay? If they address the hypertension first, well you can pick up the hypertension first, unless it contradicts any of your conventions, okay? But for the most part, again, your first listed is what we do for outpatient versus inpatient where we did our principal diagnosis, okay? Let's see what kind of example they had here. So for outpatient surgery, code the reason for surgery. So let's say, the patient goes in for they call it a phaco emulsification of their eye because they have a cataract. Obviously here, there is no essentially diagnostic test. They already have all the tests done. They're giving you the reason already, the cataract, right? So it's kind of, pretty straightforward. The reason for the surgery is a cataract. So that's the code you pick up, okay? For your observation stay, for medical observation, code the medical condition. What would be a good example of an observation? Let's see. Somebody throw examples up. I can't think of any. Why would we go for observation?
Taking out wisdom teeth? Oh, no, wait, that's not right.
What
A
about
gallbladder?
like stress tests, where they give them like the dye stress test and they have to stay in like the waiting room to see like how.
I don't know if that would solve. What was the other one you said?
Taking out a gallbladder or something?
Yeah, I'm trying to think of, anyways, there has to be a better example than the one we talked about, but, essentially the same thing. If the patient is being seen, is being, observed, what is the reason for their observation? Let's say,
Like the hysterectomy, and then you stay overnight for observation.
sure, yeah, so then let's say for the hysterectomy, obviously you had a reason the hysterectomy was done, right? Let's say for whatever reason it was, cancer. Let's say for, cancer, they had to remove all of that stuff, so the reason for the stay would be the cancer, right? Another one that I was trying to think of is, let's say you have a child who drowned, right? You obviously need to make sure that you're good to go, right? What was the reason for the observation? It was because they had the drowning, right? So, the outpatient are a little bit more cut and dry. It's essentially, why was the patient seen? If they were seen for X, we code X. If they were seen for X and Y, we code X and Y, okay? Outpatient is, I don't wanna say it's a little bit easier than inpatient, but it's a little bit. There's less guidelines, if you can tell. Section 4B, your codes from A00.0 through T88.9 and Z00 through Z99. These are, any of these codes can be used to identify diagnosis or other reasons for the encounter or visit. So if you look on page 104, you have there your B section, which tells you the same thing. These are used to identify diagnosis, symptoms, conditions, problems, complaints, or other reasons for the encounter or visit. Let's see if I can find a Z code. I know there is. Okay, so I'm gonna jump to 1322, page 1322 in your ICD 10 book. You have there your Z code. So you can see there, Z44, your encounter for fitting and adjustment of external prosthetic device. 1322, 1322. So again, that first column, Z44, encounter for fitting and adjustment of external prosthetic device. So let's say, the patient is gonna see their doctor or that specialist for the fitting of their external prosthetic device. You may not have a condition as to why they need the device, but you know that they're going for that fitting and adjustment, right? So the only applicable code would be the Z44. If in that same visit they tell you, oh, they're here to be fitted for that device because they have whatever other condition, then you would code your Z code and that other condition, okay? But this is for outpatient, okay? So this is where your Z codes apply. If you look through all the Z ones, you can see encounter for adjustment and management of implanted device, Z47 orthopedic aftercare. Essentially your Z codes, you also have Z23 with your encounter for immunization. Let's say, the only reason you're going is to get your flu shot, right? you don't have signs, you don't have symptoms, you don't have any confirmed conditions, you're solely only going for that flu shot, the only code you would use would be the Z23 encounter for immunization. Okay, that one is on 1318. I went a little bit back. So again, your Z codes apply as well, and then your A through T codes also apply for the reason for that encounter. Alright, accurate reporting of ICD-10-CM diagnosis codes, documentation should describe the patient's condition. Again, same thing, your documentation should obviously tell you why was the patient there, what was the reason. If they were there for immunization, the note should show we're here for immunization. If they were there to follow up on their diabetes, they were there to follow up on the diabetes, here's our diabetes code, end of story, okay? For D, codes that describe symptoms and signs. Okay, this is another one where we talked about codes that describe symptoms and signs as opposed to diagnosis are acceptable for reporting purposes when a diagnosis has not been established or confirmed by the provider. Chapter 18, your symptoms, signs, and abnormal findings contain many but not all codes for symptoms, okay? This is on 104 in our workbook. Let's say, for example, you're going to see your primary care because you have a runny nose, a sore throat, you have fever, you have chills, and then let's say whatever other similar signs and symptoms. But let's say your doctor told you, oh, you have an upper respiratory infection, and he confirmed it, right? So he's confirming all of these symptoms. We're confirming an upper respiratory infection, so what are you coding? Your upper respiratory infection. You don't pick up your signs and symptoms because, again, the doctor is confirming that you are active, okay? E, encounters for circumstances other than a disease or injury. ICD-10-CM provides codes to deal with encounters for circumstances other than a disease or injury. The factors influencing health status and contact are your Z00 through Z99. So again, the same example, using that, you're going in for your flu shot, the only code you would use would be your Z23, okay? Alright, we're gonna kind of jump through these real quick. Level of detail and coding. Codes with 3 characters are the headings of a category code that may be further subdivided. Again, this is where we tell you that specificity, okay? Please make sure you are reviewing the documentation to provide the most specific diagnosis possible. Use of the full number of characters required for a code, absolutely. So again, if we are looking at, let's say, an injury of the arm, please make sure you're looking for that laterality. Is it left? Is it right? Is it bilateral? Because again, your code will differ between those elements. For G, ICD-10-CM code for the diagnosis, condition, problem, or other reason for encounter or visit. First code represents condition chiefly responsible for the visit. Additional codes describe coexisting condition. Again, this is outpatient, okay? So what is the reason that the patient went to go see their doctor? Oh, they went because they have a hyperglycemic episode of their diabetes, and they need to make sure their meds are okay. Do they need to change or what have you? So then there you would document, you would code the hyperglycemic episode of the diabetes. And let's say they also have hypertension, they also have asthma, you would code those as well. But the first one, your first listed, would be the reason why they went in, which was the hyperglycemic diabetes, okay? H, okay, here's the uncertain diagnosis, okay? Remember, we had an inpatient and now we have an outpatient for uncertain diagnosis. Page 105 in your workbook. Do not code diagnosis documented as probable, suspected, questionable, rule out, compatible with, consistent with, or working diagnosis or other similar terms indicating uncertainty, okay? This is outpatient, okay? I cannot stress that enough. In outpatient, you do not code those conditions, okay? Rather, code the conditions to the highest degree of certainty for that encounter or visit, such as symptoms, signs, abnormal test results, or other reasons for visit. I'll give you an example. Let's say the patient comes in with fever, chills, sore throat, all of that good stuff, and the doctor documents in their A&P, it's probably COVID, or it's probably flu. Are we coding the COVID or flu? No, okay, we're gonna code the sore throat, we're gonna code the fever, the chills, the runny nose, okay? So again, in outpatient, you do not code those conditions that have those words, questionable, suspected, working diagnosis, consistent with, or any similar terms, okay? So again, if you do encounter an encounter or a chart that has those words and you see, okay, the doctor did write, they have these other symptoms, we can code those other symptoms, okay? So again, uncertain diagnosis is completely different from your in outpatient versus inpatient, okay? In outpatient, we do not code. In inpatient, we do code, okay? Everyone understands that? Okay. Chronic diseases, coded and reported as many times as the patient receives care, okay? So there on the same page 105, chronic diseases treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care for the condition. I'll give you an example. Patient goes in to see their primary because they have an asthma attack, right? They have an asthma attack, but they're also diabetic, they also have hypertension. During that same visit, the visit was primarily because of the asthma attack. The doctor provides their albuterol, they provide whatever they need, and they also say, you know what, let me look at your A1C while you're here. Do you need any refills? Do we need to change your dose for your diabetes, what have you? If they do complete that treatment within that visit, you code those chronic conditions, okay? Unless, for whatever reason, the note tells you, patient has all of these chronic conditions, but we absolutely did not touch base on them, then you only code the reason for that visit, okay? But you do have a rule in your guidelines for chronic diseases which tell you if they are treated on an ongoing basis, they may be coded and reported as many times, okay? Please remember your chronic diseases, okay? And this is for outpatient, okay? I can only stress that, outpatient, okay? There it also tells you, do not code conditions previously treated and no longer exist, okay? Give you an example, the same one, they go for the asthma and the doctor writes in the note, patient has a history of diabetes, no longer depends on metformin, insulin, whatever. So right away the doctor's telling you they have a history of the diabetes and they no longer receive treatment. Are we picking up the diabetes? No, okay? Let's see what else. Patients receiving diagnostic services, okay? Sequence first the diagnosis, condition, problem, or other reason for the encounter in the medical record to be chiefly responsible for the outpatient services. It even tells you there, codes for other diagnoses such as chronic conditions may be sequenced as an additional diagnosis, okay? So again, let's say that we're going to diagnose that upper respiratory infection or that exacerbation of asthma, but also the doctor documents the patient has diabetes, hypertension, we're keeping the same meds or what have you, you also pick those up, okay? It continues on, for encounters of routine lab radiology testing in the absence of any signs or symptoms or associated diagnosis, assign Z0189, encounter for other specified special exams. Then you also have another rule, if routine testing is performed during the same encounter as a test to evaluate a sign, symptom, or diagnosis, it is appropriate to assign both the Z code and the code describing the reason for the non-routine test, okay? For the most part, the rest of the guidelines are related to outpatient. Please make sure you are reviewing those guidelines. You also have patients receiving therapeutic services only, patients receiving pre-op evals only, ambulatory surgery, routine outpatient prenatal visits, encounters for general medical exams with abnormal findings, encounters for routine health screenings, okay? You do have those individual sections of your outpatient coding guidelines. Please review them, okay? The rest of the slides go over the same ones I just mentioned. Excuse me. If you do not have any questions, I will let you go. Other than that, please make sure you are completing your exams, your assessments, assignments,